And I would say that in-office dispensing is the best way to get medications to patients. We need to talk about the patient. It's about the patient and making sure the patient is cared for. In-office dispensing allows financial advocates within the team to work with the pharmacy team to make sure the patient has access and coverage for that medication. In addition, real-time dispensing. Again, back to the patient. The anxiety of a patient having to wait days or weeks to start a treatment that in their mind may cure the disease, think of the stress that puts on the patient. Whereas in-office dispensing, they have their primary care team, their physician, right there to counsel them, get them medication within 24 hours, and have a really sophisticated monitoring system.
Right, I think when you have the capabilities, as long as you're complying with the state regulations and federal regulations, you should be allowed to give like in-house dispensing. I think the major hurdle was for small practices if they don't have the capabilities to do labeling and actually storing the medication and documenting that and doing outcomes and education. I think as long as we have those capabilities, we should be able to deliver in-house.
And I wonder if it would even reduce costs, because we have to keep 2 office clerical coordinators just to deal with these specialty pharmacies. Just to, you know, be the step between the patient and the pharmacy.
Which is counterintuitive, because supposedly you're supposed to get actually help from them.
Right, exactly.
And then the paperwork that we have to fill out.
And the paperwork and the back and forth and the phone calls, it's just an extra step.
So if we can admit, and what I hear you saying is it's better for the patients to have no delay in getting the drug, which would mean that you go to your physician. The physician says you need this drug, here's the drug. And with the proviso, and I think that you alluded to this, that you've got to be certified. You got to know what you're doing, got to label it right, so there's got to be some minimal standard in the office. That it's good for the patients.
Yes.
It's good for the providers, because you can get your patients the drugs that they need. So what are the implications for the payers, and why aren't we just doing this? Somebody's got to have an advantage in not doing it, else everybody would be doing it.
The advantage to the payers is that it's delaying the patients getting the treatments. So that's all that more time that they're not paying for their care.
Always remember, it's always about the money.
Wait, no, that's awful.
No way.
That is awful. What you just said is that if you're a payer, you don't want these patients to get drugs because it's cheaper that way.
Yes.
Did you really say that?
I did.
He did say that. Is that true? Have you seen that? Do you believe it?
Well, I see all the spectrums of but I think in some cases, we may, which probably were just paying for the sins of our past, where there was not really a lot of regulation around it, so there's a lot of mistrust from certain providers and payers to deliver certain medications, and this is an area of very high cost of care overall. So they need to have like a gatekeeper, which in this case, the specialty pharmacists. They may be actually pretty good in delivering the right drug, because it's also in their interest to deliver the medication to the patient, and they will do the pre-authorization process for each patient. But of course, the insurance companies prefer to have something, a third party that is not related with the physician, to maybe help with that.